So what's the difference between positive behaviour support and psychology? I think this is the million-dollar question almost, particularly at the moment. Positive behaviour support is not psychology. And, you know, there are some parts that overlap to some degree because the theory behind both models is similar at times. Not all the time, but at times. But really what the positive behaviour support practitioner and what the psychologist are doing are quite different. It's just that they're drawing from the same models of understanding. So also psychology in an NDIS space is different to psychology in a non-NDIS space. And this is why we're hearing a lot of talk about psychology is funded under mental health, because it absolutely is. The psychology that's funded under the NDIS is not the same as the psychology that's funded under mental health. However, again, the theories are the same. It's just the actual work or the focus that the person is doing will have the psychologist is doing will be a little different. So psychology at its core focuses on, in the NDIS space, focuses on thoughts that a person has and how their thoughts relate to their or drive their feelings, and how their feelings relate to and drive their behaviours. So a psychologist will talk very much to someone about what are they thinking, how are they feeling, and how that impacts their behaviour and how that becomes a cycle. In psychology, we call it cognitive behaviour therapy. And the psychologist will work with the person on understanding and awareness of their emotions as they relate to physiological, how they feel, but also as they relate to what they're thinking and how they're behaving. And in the NDIS space, the psychologist is looking at functional capacity building. So understanding how my thoughts and my feelings affect my behaviour and looking at what skills I need to build my independence and capacity. So for example, as a psychologist, I may see someone who is NDIS funded who has I see an autistic person who is having difficulty making friends or interacting with other people, very common for some people on the spectrum. And I'm talking to them about what are they thinking when they see someone they'd like to be a friend with, how does that make them feel? And then I'm looking at, you know, what they could do to try to make friends and encourage them to learn strategies that may work. I may even work with a speech pathologist around some social skills with that as well. But I would work with someone around their feelings, their emotions, their thoughts, and their behaviours in developing that skill to learn how to make friends, interact with other people. A psychologist in the non-NDIS space would be talking about things like anxiety, depression, and working in a similar model on those kinds of disorders and difficulties as well. So those are the two differences for psychology, I guess, in the NDIS space. The other thing is psychology is usually sessional. And most of the time we provide psychology direct to the person. If the person is a child, we may involve the parent in the sessions as well. However, it would not be common practice for a psychologist to work as much with carers as a positive behaviour practitioner will. Psychology rarely requires long written reports in the NDIS space other than the report to NDIA. We would usually not focus on mental health directly, although we may be focusing on symptoms of mental health that are related to functional capacity and disability. I won't go into that too much, but there is a slight difference. So if you're psychology funded, or if you want to see someone on a sessional basis every fortnight to work on things like feelings, emotions, thoughts, and my behaviours, you're wanting psychology funding. If you're wanting to, and I'll go into PBS and what you'll be looking at there, but this is what psychology is. The other one I hear a lot used instead of positive behaviour support is behaviour therapy. And I think that's a very layman term for behaviour support, but recognising it's actually a technical term in psychology as a model of providing psychological support. So, and we often put cognitive in front of it. So there's cognitive behaviour therapy as a model that we will use as a psychologist, and there's behaviour therapy, which is part of that model that we will use as a psychologist. It's not positive behaviour support again. So the easy way to think of this is behaviour therapy is psychology. Positive behaviour support is not. Behaviour therapy, again, focuses on thoughts, feelings, and behaviours. It just doesn't focus on the thoughts as much, is probably the easiest way to put it. But it is about understanding feelings and understanding how feelings relate to behaviours, which they do for all of us. Often how we feel impacts how we behave, and it's about educating a person, helping them understand that link, and then helping them recognise their emotions and identify other strategies. That is psychology. That is behaviour therapy. So what is positive behaviour support? So positive behaviour support is an assessment. It starts with an assessment that looks specifically at the behaviour and what's happening around it. So we don't necessarily go straight to the cognitive, the thoughts of the person. We look at what is the behaviour and what is its function? What is the person using the behaviour to try to communicate? So it focuses on specifically outlining what the behaviour is, when it occurs, how frequently or often it occurs, does it have different intensities, what happens before it, what environment does it occur in, and what happens after it. And that gives us a really good picture of specifically when that behaviour is used by that person. Then we will also look at who is this person? What are their aspirations? What do they like? What are their goals? What do they enjoy doing? Where are the gaps in their life? So often we're looking in positive behaviour support at functions, to put it very simplistically, and it isn't always this simplistic. In fact, it really is. Someone might use a behaviour to communicate, I'm in pain. So you and I would say to someone often, my head hurts. Now, if you can't say that because you have communication difficulties, or for whatever reason you don't feel comfortable to say that, or you've said it in the past and it doesn't work, people haven't responded to you, you might start to use another behaviour, and it could be a variety of behaviours to communicate you're in pain. The positive behaviour practitioner would identify the function of this behaviour. Let's say it's hitting my head. The function of this behaviour when I hit my head is to communicate I'm in pain. So as the behaviour practitioner, I would then identify, once I've established that's the function, I would then identify what is another way we can support this person to communicate I'm in pain that doesn't involve them hitting their head. And it could be a variety, again, of other tools or strategies. We would work with the person and their carers to identify that. We would most likely need the carers in the environment and the person as much as we can to understand what this new strategy is, and when they use the new strategy, reinforce it. So positive behaviour focuses on changing the environment to reduce a person's behaviour sometimes. So it's, as opposed to psychology where we're working directly with the person and teaching them awareness, positive behaviour support often looks at the environment and makes what we call environmental manipulations, remembering that often the carers are part of the environment, to reduce that person's need to use challenging behaviour or behaviours of concern. It's about teaching others how to respond to the behaviour so that the person doesn't need to use it anymore or gets what they need out of it in the short term while we teach them new strategies. It's about teaching them skills that directly relate to why they're using that behaviour. So that's why you will see your behaviour support practitioner come in and do quite a detailed assessment of the specific behaviour and what's happening around it, as well as the person, their lifestyle, who they are. Then they will go away and identify all of these, this function for this behaviour, this function for this behaviour, and look at, if that's the function, what strategies can we put in place in the environment? What can we teach this person so they don't need to use this behaviour anymore? How am I going to work with the person and everyone in their environment and their environments? And how am I going to monitor what we're doing and see if it's working? And with the ultimate outcome focused on building quality of life. Because when you build someone's quality of life, it usually means you reduce any behaviours of concern. So positive behaviour support will involve a behavioural assessment and a written report. So when you're accessing positive behaviour support, you're usually accessing positive behaviour support because you have some behaviours of concern. They're usually a safety risk or a risk of harm. And we need to understand why these are occurring. And we're going to work with everyone in the environment and the person to develop skills so they no longer need to use them in the future. Again, that's a very simplistic outline. It's not always that easy. And to be really honest with you, it can take an extensive period of time to develop those skills, particularly in someone who's been using those behaviours to get what they need for a longer period of time. But it can be very, very effective. So when we're looking at positive behaviour support, we're looking at working with the person and the carers across multiple environments. So your behaviour practitioner will come into home, any work placements, any schools if it's a child, and we'll look at the behaviour in each of those environments and work with the support networks in each of those environments. A psychologist will usually only work with the person, maybe the parents. They will often consult with other people that are important to the person, but they don't tend to work as closely with them as the positive behaviour practitioner will. Positive behaviour support looks at why the behaviour occurs and then identifies gaps in the person's life that cause those behaviours, whereas psychology will work with the person to understand their behaviours, their emotions, and change how they respond to that. The positive behaviour support will write a written report that outlines the function of the behaviour, the strategies to be implemented. And it is quite a lengthy report. That report is dictated under NDIS, if they're NDIS funded, in exactly what it has to be, and the length, pretty much the length of it, because they're dictating what's in it. The psychologist obviously keeps case notes, as does the behaviour practitioner, but there's no requirement there apart from to report back to the NDIA with that report when the NDIS plan is due for review. There's limited documentation that's required outside of case notes and maybe some resource development. That's a massive difference that I think people don't, we don't educate people well enough in understanding what that means and how useful that report is, particularly the strategies. And I think that's the practitioner that needs to educate people around that and help them to understand why we do the reports that we do. The positive behaviour practitioner will trial strategies with the person, with their stakeholders, their support network, and trial strategies. And if they're not working, they should be changing them along the way. It is a little bit of trial and error of what works for individual people. The psychologist does similar, but they only work with the person usually, or maybe the parents, to trial interventions in that fortnightly sessional model. This was one of the things when I provided both behaviour support and psychology long before the NDIS is often I would be providing psychology support to someone who had good communication skills, verbal communication skills, and could understand the link between their emotions and behaviours, because at the core of psychology is teaching someone my thoughts affect my emotions, affect my behaviours. That was a lot of what I was doing as a psychologist supporting people with disabilities. And I mean, that's again a simplistic version of it, but essentially that's what I was doing. So if I'm providing psychology to someone, I need to be able to communicate really well with them. Whether I use adaptive communication techniques or verbal communication, I do need to be able to communicate well with them to teach them these new skills, to teach them an understanding of emotions. I can bring emotions to a more concrete level than happy, sad, angry, excited by using a variety of tools as a psychologist, because the concepts of sad, happy, angry are quite abstract. But I can bring them down to a more concrete level to support a person with a disability. But I do need to be able to have that ongoing communication. Whereas in positive behaviour support, I can support someone with a varied communication difficulties and varied, I guess, cognitive difficulties as well, because I'm working so much with the environment and their support network. I'm still getting to know the person, but I can do that in a variety of ways. Whereas when I'm teaching them about emotions and behaviours, that communication is very different to what I can do to build rapport and get to know someone and what they like and what they dislike. So often I would use the behaviour support model when somebody couldn't, I guess, fit in with what is the traditional psychology model, and if they had behaviours of concern. So those are the differences between PBS and psychology. And I don't think it's spelt out very well. I don't think we will often see plans that have been developed where the planner doesn't know the difference. And I understand, because it's actually quite complicated at times, but the way we work in both models is very different, even though the theories are very similar.